Hi everyone, welcome back to the Med Student Success YouTube channel. Thank you so much for joining us. Today we'll be doing a really high yield topic. We'll be talking about biostats. Like always, we'll be going over some high yield clinical presentations. So let's get started. If you need some extra questions, we've partnered with TrueLearn to offer you 25% off of their question banks, and you can use our link in the description box below, and our discount code is SUCCESS25. So first, I want to start off by talking about different types of observational studies. So the first one compares people with disease to people without disease, and we calculate the odds ratio with this. This is case control. So remember, cases are people with the disease, controls are people without the disease, and we calculate the odds ratio. Next, we have a study that compares people with a risk or exposure to people without the risk or exposure, and we calculate relative risk. This is a cohort study. Next, we're going to describe several individual patients with the same diagnosis, treatment, or outcome. This is a case series. Next, we have a study that takes a snapshot of the disease and risk factors assessed in the present, and we can calculate the disease prevalence through this. This is a cross-sectional study. Next, we have an experimental study involving humans. This is a clinical trial. Next, a type of study that compares the effect of 2 or more treatments. This is a crossover study, and remember, in this study, there's a washout period between the treatments. Next, it's a type of analysis where all the patients are analyzed according to their original treatment and no one is excluded. This is an intention to treat analysis, and we like to compare that to the next one, where we only analyze patients that completed the study properly. This is per protocol. And remember, the intention to treat is more similar to our real practice, because a lot of times patients don't actually do what we prescribe in an organized manner. And so intention to treat often simulates actual clinical practice. Next, we're going to be talking about the drug trial phases. So guess the phase of the drug trial that involves a small number of volunteers to assess whether the drug is safe. This is phase 1. Remember, phase 1, small number of participants, and we're assessing safety of the drug. Next, we have a moderate number of patients with the disease to assess if the drug actually works. This is phase 2 of the clinical trial. Remember, here we want to see if it actually works in people who have the disease. Next, we're going to have a large number of patients with the disease to assess if the drug works better than the current treatment. This is phase 3. Next, we have post-marketing surveillance to assess the long-term side effects of the drug. This is phase 4. Next, the formula that we use to calculate this is AD over BC, and it's used in case control studies. This is the odds ratio. Remember, the odds ratio is used in case control studies, and it represents the odds of an exposure among the cases versus the odds of exposure among the controls. Next, we have the formula A divided by A plus B, and then we divide that by C divided by C plus D, and this is used in cohort studies. This is relative risk. Remember here, it's the risk of developing the disease in the exposed group divided by the risk in the unexposed group. Next, we have the formula true positives divided by the true positives and the false negative. This is used to rule out disease, and it makes a good screening test. This is sensitivity. Next, we use the true negative divided by the true negative plus the false positive, and we use this to rule in disease, and it's for confirmatory testing. This is specificity. And remember, a highly sensitive test has to have a low false negative rate, and a highly specific test has to have a low false positive rate. Next, it's going to be a probability that a person who has a positive test actually has a disease, and we use the formula true positive divided by the true positives and false positives to calculate this. This is the positive predictive value. Compare that to the next one where we have the probability that a person who has a negative test actually does not have the disease. And we calculate this value by using the formula true negatives divided by the true negatives and the false positives. This is the negative predictive value. And important concepts here to know are that sensitivity and specificity don't change with prevalence, but the positive predictive value and the negative predictive value do change with prevalence. Next, we have different type of bias. So the first one's going to be a population in the study not being representative of the target population. This is a selection bias. And remember, oftentimes we use patients in the hospital, and sometimes, having patients just in the hospital aren't representative of the whole population. So that's an example of selection bias. Next, we have a common bias in retrospective studies like case controls. This is recall bias. And remember here, awareness of the disorder alters the recall of the subjects. And so in case controls and cohorts, a lot of the time recall bias can affect the study. Next, we have a bias where the researcher's beliefs change the outcome of the study. This is observer expectancy bias. Next, we have a third variable related to both the exposure and outcome that affects the results. This is a confounding bias. Next, we have early detection in a screening test is interpreted as increased survival, even though it's not. This is lead time bias. And remember, anytime you see the word screening test in the question, and they're asking about a bias, pick lead time bias. Next, we have a slowly progressive disease more likely being detected than a rapidly progressive disease. This is length time bias. Next, we're going to be talking about types of testing errors. The first one states that there's an effect even though none exists. This is type 1 error, also called alpha. And we compare that to the next one, where we state there is not an effect when there actually is an effect that exists. This is type 2 error, or beta. Remember, type 1 error is also called the false positive error, and type 2 error is also called the false negative error. And something important is that if you increase the sample size, you increase the power, and that decreases the type 2 error. Okay, now we'll be talking about types of statistical tests. So the first one is going to compare the means of two groups. This is the t-test. The next one compares the means of 3 or more groups. This is ANOVA. Next, the test is going to compare 2 or more categorical outcomes. This is chi-squared test. And if the sample size is very, very small and we want to compare the categories, then we use the Fisher's exact test. Okay, so we're going to do a quick high-yield review of some important bullet points I'll go over, followed by some high-yield formulas that you need to memorize, and then we'll do some questions. So the first thing I want you to know is that sensitivity and specificity don't change with prevalence. Positive predictive value and negative predictive value change with prevalence. Positive predictive value increases with prevalence, and negative predictive value decreases with prevalence. So they go in opposite directions. Precise and reliable tests are tests that are very, very consistent. So you keep getting the same results again and again. Accurate and valid tests are close to the true values. The mean, which is like the average, is the most affected by outliers, and the mode, which is the number or the value that you get the most common, is the least affected by the outliers. A positive skew has the longer tail on the right, which means that the mean is higher than the median, which is higher than the mode. A negative skew has the longer tail on the left side, and it's the opposite of a positive skew. So the mean is less than the median, which is less than the mode. And remember, increasing your sample size increases power and decreases type 2 error. And also, it narrows your confidence interval when you increase the sample size as well. Okay, so now some high-yield formulas. Something you want to commit to memory is this table. So remember, at the top we have the disease, positive in this column and negative in this column, and then the exposures are present in this column and the exposures are absent in the column at the bottom. So right here we have the true positives, over here we have the false positives, here we have the false negatives, and here we have the true negatives. So this table will really help us with the important formulas and to answer some of the questions on exam day. So the first important formula is sensitivity. That's where you take the true positive over here and divide it by the true positive and adding the false negative to that. So pretty much this column right here, again, true positive divided by the total sum of this. Specificity, you use the column right beside. So you do the true negatives divided by the true negatives and the false positives. Positive predictive value, you're going to go this way now. So you take the true positives and divide that by the true positives and the false positives to get your value. For negative predictive value, you start with the true negatives and divide that by the true negatives and the false negatives. The odds ratio, you multiply A and D and divide it by B and C. For relative risk, you take your A and you divide that by A plus B, and then you divide all of that by C divided by C plus D. Your relative risk reduction is 1 minus your relative risk, which is the calculation I just showed you. Your attributable risk is pretty much just your relative risk, but you minus it instead of dividing it. Your absolute risk reduction is exactly like your attributable risk, but C divided by C plus D comes first. And it's usually just the bigger number minus the smaller number. So that's how you can kind of remember that one. For number needed to treat, you take 1 divided by your absolute risk reduction. For your number needed to harm, you do 1 divided by your attributable risk. Okay, and remember, it's the bigger number. So that's how you know which one to add or subtract first. And remember, your number needed to treat is a number of patients who need to be treated for 1 patient to benefit. So it's better if you have a lower number because it's a better treatment. And then for number needed to harm, it's a number of patients who need to be exposed to a risk factor for 1 patient to be harmed. So a higher number for number needed to harm is a safer exposure. And then incidence is the number of new cases divided by the number of people at risk. And then prevalence is the number of existing cases divided by the total population. So these are some really high yield formulas that you should commit to memory. And then we'll incorporate these into different vignettes. And that's how they'll usually test you on the STEP exams. So for question 1, we're going to have a study that compares mean HbA1c levels in 4 different diabetes medications. So what is the best statistical test? Is it t-test, chi-squared, ANOVA, or logistic regression? So it's ANOVA, because remember, ANOVA is used to compare the means of 3 or more groups. If it was just 2 groups, you can use the t-test. If it was comparing 2 categories, like males and females, to like having diabetes or not having diabetes, that would be chi-squared. So for question 2, we're going to have women with breast cancer asked about prior hormone use and over-report compared to controls. So what type of bias is present here? Is it selection bias, recall bias, confounding, or observer bias? Here it's recall bias, because remember here, retrospective studies like case controls can have recall bias. Question 3, we're going to have the same test is applied in a population with a very low disease prevalence. So what happens to the positive predictive value? Does it increase, decrease, unchanged, or become equal to the sensitivity? So remember, it decreases because lower prevalence, we have more false positives and a lower positive predictive value. And in this case, negative predictive value would actually increase. Question 4. So a new screening test for colon cancer is evaluated. Among patients with biopsy-proven disease, 90% test positive, and among patients without disease, 80% test negative. So what's the sensitivity here? So here the answer is 90%. So remember, for sensitivity, we take the 2 positives and divide that by the sum of the true positives and the false negatives. So in the question stem, it says that there's a 90% test positive. So if we assume that there's 100 patients that have the disease, a 90% test result shows that 90 of these people are true positives, right? Because those are the ones that are biopsy proven. So 90 people are true positives, which means 10 are false negatives. So we take 90, which is the true positive rate, and we divide that by the true positives, which is 90 again, plus the false negative, which is 10. And we get 0.90, which is 90%. Okay, so I hope that makes sense. If you have any questions, please reach out through email or through our website. I really hope that you found this was helpful. Thank you so much for listening to the video, and please shoot us an email and visit our website for lots of more helpful material and resources. Please like, share, comment on the video, and let us know what you'd like to see in the next video. Thank you so much for watching, everyone. Take care.